Healthcare accounts for more than 40% of the provincial budget, and according to a new study, a third of that spending goes to treat just 1% of patients. Health economist Walter Wojcik joins us now to break down the numbers. He's an associate professor at the Institute of Health Policy Management and Evaluation at the University of Toronto. And Walter, it's good to have you here at TVO.
Thank you very much.
We are going to bring up a graphic to start with here, which you are going to take us through, which shows, actually, why don't we just do that? There it is right there. This looks more complicated than it really is. If you take the left, you'll see the percentage of the population, and if you take the right, you'll see what we're spending on them. And you can take us through this, Walter, starting with that top band, which is red. The top red band is very small, but the amount of money we're spending on that small group is very large. Take us through it.
Sure. So this does take the entire population of Ontario, over 13 million people, and the people where they consumed $0 in healthcare resources on that left bar are at the bottom. And the people with the highest spending, hundreds of thousands, are at that top left. That's that 1%. And when we look at how much of the total expenditures that are allocated, so 1% of the population there, we see it, they're consuming a third of all healthcare costs, and just 5% consume 2/3 of all healthcare costs. Another very interesting feature is that the median costs, so half of the population only use up 2% of the total health system spending.
So we need to know more about this 1% at the top that are taking such a disproportionate share of the healthcare dollar. Who are they?
So they have a number of different conditions, but they're really very, very ill people who require a lot of care. Surprisingly, many of them have chronic, or not surprisingly, perhaps many have chronic conditions, but they have multiple chronic conditions. And they spend a lot of time in the hospital, and they're re-hospitalized, and they come back to the community, and they try and get stable, but then they come back into the hospital again. Some of them have very severe accidents, and they might require inpatient care, followed by weeks or months of rehabilitation care, followed by more home care, and all the way through physician visits.
The assumption is these are all people, not all, but overwhelmingly people in their 90s who are not long for us. Is that accurate?
No, that is not entirely accurate. There are some of those people, it's true, but we have children who are low birth weight children, who have other people who have children who have complications, and then we have adults. Adults get cancer. Some of them are very complicated cancers. Some of them have multiple chronic conditions, even in their 40s and 50s. Some people don't have very healthy life, and then there are, the majority of them still are the older people, 65 and older, but it's not all end of life. Okay. Not a high proportion of these people die in any year.
If we spend, I don't know if it's even possible to break this down, but we spend $50 billion roughly a year on health, more than that, $50 billion in the province of Ontario this fiscal year on health. Can you say how much of that $50+ billion actually goes to treating patients directly as opposed to administration, all of the other stuff?
Yeah, sure. So it's so there's not only administration, there are general programs. So administration in Ontario is generally below 5%, but then we have a lot of community type programs, so public health programs, public health units, and centers such as that provide general population health, and that consume about another 15% of the healthcare budget, and then about 80% is spent on individual care.
Okay, but that public health is important stuff, right?
It's absolutely important stuff. Yeah. And those community resources and programs are very important.
I mean,
and people use them. They're not just only for specific people.
Yeah, right? I mean, presumably if we, well, I don't know this, you tell me, if we spend more on that 15%, we might be spending less on the 80%? Is that possible?
So it's possible. There's not really hard evidence to suggest that there's a direct relationship. However, it is shown that countries that have higher social spending programs tend to have better health.
Okay, let's go through a second chart here. And again, talking about those very high cost patients, that 1% that take up a third of the budget. I gather the technical term for that is multimorbidity, is that right?
Yes, so multimorbidity is the issue of having multiple chronic conditions at the same time.
Okay, you want to take us through this chart and give us a sense about how multimorbidity shows up on the bottom line?
Yeah, absolutely. So this chart shows us among people who don't really have any conditions at all, it make up about half of the entire population of Ontario, but they consume relatively few resources. And then incrementally, as we add each one condition, we see that costs on average go up incrementally, and that the amount of the total budget that is going to care for those people increases a lot. So there's only about 500 and some odd thousand people who have 5 or more of chronic conditions. We have a subset of 17 that we're looking at here. They're the most common conditions.
Should we go through it? Let's go. I think we've got the list of that here. You've pinpointed 17 medical conditions that are most often found in these high-cost patients. It starts at A and goes almost all the way to Z. A for acute myocardial infarction, all the way down through arthritis, asthma, keep going, depression, renal failure, down to stroke as we get into the S's and further. How did you manage to identify these 17?
So these are actually based on international work on non-communicable diseases. So these are diseases that appear all over the world to be high-burden conditions because they either cost a lot at an individual level, such as something like stroke, which can be very debilitating and also leads to long-term consequences. People are often suffering from their stroke conditions for long periods of time, or really high prevalence. So things like hypertension for one person are not that expensive, but so many people have the condition that at a societal level, it's a very high burden condition. So all of these, for one reason or the other, are very high burden.
I'm looking at the list, Walter, and there's one thing not on the list that I thought would have been on the list, and you can tell me why it's not on the list, and that is, I guess you call it trauma. You know, you get hit by a car, you would think that you are a very expensive prospect for the healthcare system after that. Not the case?
Okay, so 2 things. Some of those people are, but their care is relatively unpredictable, is a very short period of time. Not always. Some people do suffer for conditions a long period of time, but many of those people are treated as acute patients in an acute care, and then they'll go out and they'll live the rest of their lives without any problems. All of the conditions that we're considering in this study and all of this work are conditions that actually last over long periods of time. And so not only are they high cost this year, but they actually continue to be high-cost individuals over multiple years.
Whereas presumably if you get hit by a car, you will at some point be better.
For the most part, yes. There's a very small percentage of that population have debilitating conditions. Most people recover.
We've got another graphic here because we want to look at conditions that, again, you have pinpointed that lead to hospital admissions by stages in people's lives. For example, we've got low birth weight, we have preterm infants, we have depressive episodes, chemotherapy for neoplasm, acute, you want to help me with this word?
Bronchiolitis.
Bronchiolitis, there we go. What is that anyway?
So it's a lung infection.
Oh, okay. Why can't you just say lung infection? Oh my goodness, you people in medical. Okay. Depression in children can lead to hospitalization?
So youth. So this is under 18. We define children here up to age 18. And you may have actually heard, there's actually youth mental health issues are quite a significant concern and are an increasing concern. And how to address their issues requires not only, and we'll get into some of this later again, I hope, the healthcare system, but also the school systems, the social care systems, a broad social network, because it's not necessarily something that a physician entirely on their own can manage.
That's children. Let's now take a look at the next chart. These are the top reasons for hospital admissions if you are an adult. Atherosclerosis, COPD, chronic obstructive pulmonary disease, palliative care, congestive heart failure, chemotherapy for neoplasm. Okay, again, that last one, what does that mean?
Cancer.
That's cancer. And again, you couldn't just say that, eh? Okay. Help me out a little bit here, Walter. Should we do the...
So one comment about those conditions is how disparate they are. So everything from cancer to heart surgeries. There are many, so what we found with the adult population, so 18 to 64, is that there are many different kinds. Some of them were chronic, but many of them were acute conditions as well. And that makes it difficult to know how do you have a population response to a specific condition. You can't really. You have to have a broad healthcare system, and that makes healthcare very complex as well.
Let's do the third chart in these reasons why people go to hospital. We've done kids, we've done adults. Now this is among older adults. Congestive heart failure, once again, COPD, chronic obstructive pulmonary disease is on the list. Urinary tract infections, hip fractures, pneumonia. Okay, a few obvious ones there. You got heart failure, you got COPD, understand why you're going to the hospital. Urinary tract infection and pneumonia can set you into the hospital for long periods of time?
Yeah, so these people have low capability and low resilience because they have multiple chronic conditions. So someone who had no conditions and only had a pneumonia would stay at home and they'd be fine. But people who have these 3 or 4 chronic conditions, that makes them at higher risk. And when they get pneumonia, it's a very serious illness.
Let me ask the overarching question here, which is, I guess it's, well, this is why you're here. It's interesting to know why people go into the hospital, for how long they go into the hospital, the amount of money each segment of the population ends up costing. That's all interesting to know. Why is it important to know?
So it's really important in terms of how we manage and orient the healthcare system. So do we just treat these people in the hospital and that's all we need to do? Or if we find, for example, that the people with high sustained costs have chronic disease, then we need to think about how do we manage the chronic disease before the hospital. And what we're really finding in a lot of our work is that it's multiple chronic conditions, and we don't have systems that manage multiple chronic conditions. We have a diabetes strategy, we have cardiac programs, but we don't have programs for people who have dementia with arthritis and they're depressed.
So presumably the idea behind getting all this information is to improve the care of these people at a lower cost to the taxpayer. Is that the idea?
Absolutely. And what kind of care that needs to be is not just a disease management program.
Okay, to that end, the Ontario government, in its wisdom, several years ago, I think within the past decade, brought in something called health links. What are they?
So health links are really brought in to manage this issue. They're brought in very specifically to manage the care for the top 5% of healthcare users who have multiple chronic conditions, and to organize integrated care that has physicians and community care, home care, and hospitals all involved to share the care for those individuals.
And how does it actually work?
So at the front lines, it really works with care coordinators, identifying patients, physicians referring them, coming up with a care plan that is tailored to the individual, understands their conditions, and starts to put more of a management around the person instead of the disease.
The name itself, Health Links, would suggest that the disparate aspects of the healthcare system are somehow linked up to treat this one person. Does that actually happen?
So when they're high-performing health links, that absolutely happens. People are coming together to share care around patients that have never had those experiences before.
And is Health Links actually saving the taxpayer money?
So I think health links are still, so the announcements were made a few years ago, but there's probably only there's 76 health links in the province right now. I'd say a third of them are probably quite mature, and they really are better managing their care. And there's evaluation work going on that has some initial ideas along those. They won't turn down total health system costs, but they will better manage the costs for those patients. Now, but it's hard work to get people to collaborate who have never even met each other
This
before.
was exactly the point I was going to make. You've talked in the past about how the healthcare system works in silos. You know, there's the health strategy, the diabetes strategy. How do you get these different elements of the healthcare system to work together?
So that is a really challenging aspect. Some have a very natural tendency to want to collaborate. I think the more that we put patients at the front of all of this, the more everybody is willing to come around and have a discussion. So physicians really want the best for their patients, and they're happy to come and have a discussion about how their patients can be better managed and better cared for. If we just think about it as we need to have a meeting to have a new coordinated team, they might be less interested and willing.
Gotcha. Sandra, you want to do this Carl Cederstrom clip now? Okay. Earlier in January, we had an interview with a guy who wrote a book called The Wellness Syndrome, Carl Cederstrom. He's over in Sweden, I think. And here's what he had to say about some of what we're talking about right now. Sheldon, if you would, roll the clip.
There was a Dutch study a few years ago who suggested that the people who are really costing society most are people like, I suppose, yourself. You look like a very healthy man, and myself. You know, I'm a reasonably healthy person. We are the people who cost society most because when we retire, we just keep on living forever and ever. You know, a smoker, obese people tend to work and then they die. You know, from a strictly from a strictly economical point of view, they cost society much less.
Because they're not going to collect their pensions, right?
Sorry?
They're not going to collect their pensions, and therefore they'll cost us less in the end. Is that the idea?
That's right. That's right. Well, people like the two of us, I don't know, well, at least I hope we will be a big burden to society and the welfare society as we go in and out of hospital until we are very, very old.
Amen to that. Well, let me pluck a question out of that, which is something like, it might be easy to blame the patient in this case for living a bad lifestyle, smoking, for example, and therefore costing the healthcare system a certain amount of money along the way. Is that the appropriate thing to do here?
So I really don't think that's the appropriate thing to do here. People who are presenting to the healthcare system need care, and the system needs to respond as best they can.
Even if they're the authors of their own misfortune.
So I would doubt that they're entirely the authors of their own misfortune. There are many social circumstances that lead people down a whole trajectory of life that leads them to poorer health outcomes, not to mention that I think, and there's been quite a bit of debate lately about cancers, for example. Are they totally genetic or are they totally by behavior? And I think the answer is they're not either or. There's a combination of many things that go on. And many people's behavior are brought about by their upbringing and the socioeconomic status and the environmental
and the poverty that they
constructs.
have to experience and so on and so forth. But do you have the slightest bit less sympathy for the person who smokes 3-pack a day their whole life, knowing that that's killing them?
So I don't have less sympathy when they present to the healthcare system. I think that these are people where we need to have better behavioral modification programs. It's not modification in terms of somebody else doing something to them, but helping them, right? But they need to realize, and people all have to realize, that they can be more active. We can all do better. I can eat better. I can be more active, less sedentary too. So even just sitting in my desk at the university for too long of a period, even if I am an active person, can be harmful. So there's always room for improvements. And I think we just need to help people get to where they want to be.
Well, we on this program like people leading active lives as well, except of course between 8 and 9 o'clock at night when we're happy to have them sit on their couch and watch television if that's what they want to do, as long as they're watching us. But if you're watching this right now and a viewer suspects that they are part of this high care, high cost segment of the patient population, what's your advice?
So first, if they think that they are having challenges or they could use some more help in helping to coordinate, that they have many different providers and it's difficult to follow, then they should ask their physician about health links. And their physician should be able to let them know if there's a health link there should be a health link in their neighborhood and how they would get connected. There are also websites, if they were to look this up online, it won't be hard to find, by their local area. So these are geographically determined. And think about where do they need help? And to ask for that kind of help.
Do you need to get into health links or can you do it on your own?
Health links are really meant for people who have a lot of really significant challenges. They have multiple chronic conditions. I think both they and some people who are not quite that ill yet need help in many regards, right? So coaching, and that's where primary care and good community-based care can really be very helpful in helping people to understand and manage their own conditions.
Because it goes without saying that if the whole of society is healthier, we all do better.
Exactly.
Gotcha. Walter, it's good of you to come into TVO tonight and share your thoughts on this. Thanks so much.
Thanks very much.
Help TVO create a better world through the power of learning. Visit supporttvo.org and make a tax-deductible donation today.